Hello, everyone. This is Jack here. And this is a date stamp for today's event on the 10th September 2020, 6 p.m. Singapore time. This is our third in a series of our APSC Leadership Hard Talk. And today's focus is on the role of a cardiothoracic surgeon in Asia. And we welcome everyone to participate vigorously for this event. So my name is Jack. I'm from Singapore, the current president of the Asian Pacific Society of Cardiology. My speaker today is Professor Kenny Sin, the chair of education at the Asian Pacific Society of Cardiology, also from Singapore. He will then introduce the rest of our esteemed cardiothoracic surgical panel. Kenny, you're muted, Kenny. Maybe you can. Kenny, can you unmute yourself, please?
All right, thanks. Yeah. So thanks, Jack. And I have great pleasure in introducing our three panelists. They are quite important people in the Asia Pacific region. We have John Chan, whom I've known for many years. In fact, I know all the panelists for many years. And John, in addition to his many accomplishments, has been critical to basically helping informing the first National Cardiothoracic Surgery Training Program in Malaysia in collaboration with the Royal College. And I think his graduates are going to start exiting from next year onwards. So I think it's an amazing achievement. Win Rachel, I've also known for many years. She's very dynamic. She single-handedly built up a pediatric cardiac surgical unit in Yangon, and she's recently moved to the Yangon General Hospital to take over the headship. I think there's going to be a new building coming up, and I think the pressure is very high on her to deliver a world-class cardiac surgical unit, and she's got a host of trainees coming through. Last but not least, Meng Cho, I think, needs no introduction. He's got an impressive long list of qualifications. He's chief of cardiovascular surgery at his hospital. He's also got an engineering appointment at the university. It's amazing. And he's basically, I think, single-handedly basically cornered the market for minimally invasive surgery. And he's, I'm sure you have heard him speak, and it's really impressive how he's managed to develop that. Okay, back to you, Jack.
So, yeah, thanks a lot, Kenny, for the introduction. A quick disclaimer, today's webinar is copyrighted by APSC and should not be distributed without the prior permission of APSC. The views and opinions expressed in this webinar are those of the faculty members alone and do not necessarily represent those of APSC. This webinar is live streamed and recorded via Rutherford Medicine APSC Facebook and YouTube page. For Singapore registered physicians, CME points will be awarded to attendees who are active for this 1-hour webinar. You'll receive your certificate of attendance upon completing a survey sent via email after the webinar. This session is actually more interactive than usual, and I'll welcome participants to raise their Q&A freely, and I will endeavor to answer every single question. So there's no wrong question. Please ask any question you want to ask. Just a pitch, there is upcoming leadership series. The next one to be will be the future of cardiovascular imaging by Professor Jerome Bax, our ex-ESC president from the Netherlands. We have done a pre-recording for the most impactful cardiovascular trials in the last decade with Professor Greg Stone from the USA. And also to be recorded a global cardiology leadership and challenges forum with a bunch of cardiologists from across the globe. What has already went and I'll encourage people to watch this available on demand series, What Makes a Successful Clinician Scientist by Professor Caroline Lam from Singapore. And Professor Rick Chazelle, our ex-ACC president, gave us a wonderful session on getting the most out of your meetings, whether it's a Zoom or live meeting. So with that, I would like to thank everyone for participating tonight and move on to the first pre-recorded talks by Professor Kenny Sin.
So I would say if I had to go to do this again, I would have taken the road less traveled again. I'm a cardiac surgeon by training. I used to head the Department of Cardiac Surgery at the National Heart Center. Currently, I'm the Deputy Vice Chair for the Academic Clinical Program for Cardiovascular. And I have a few roles in the societies around this region. One of them is the Chair of Education for the APSC. And probably in this capacity that I'm appearing before you here. I'm also the director of the ASEAN Federation of Cardiology College. And on the surgical side, I'm the Secretary General for the ATCSA, which is the Asian Thoracic Society of Cardiovascular Surgeons of Asia.
Today's talk is about, not just about you, but I want to focus attention on what is happening to the field of cardiothoracic surgery in this environment, and how you think a person or aspiring cardiologist or cardiothoracic surgeon to be of tomorrow needs to acquire the skill set, the mindset to be a successful surgeon. I don't know who are the type of people should be doing cardiothoracic surgery. Is there a role for cardiothoracic surgeon? What type of skill set must you have? What are the qualities that you look out for? So we're going to cover some of these topics today. And maybe I can get you to give a quick lecture on the topic of who moved my cheese. Kenny.
Under this Chair of Education, we provide scholarships, we provide funding, and they are open to all people in the cardiovascular field, whether you are surgeon, cardiologist, anesthetist, interventionalist, or general cardiology. So I would say all comers, as long as you're involved in cardiovascular medicine, we support you. In my field, in particular for surgeons, I think we may well be a vanishing breed with the way things are going. The reason I'm saying that is, as technology advances, things become more minimally invasive. And if we look at what has now become catheter based, right? I think PCI is now doing, taking a lot of the work of the cardiac surgeon. Mitral stenosis rheumatic is practically gone. We hardly ever see that anymore because everything is now balloon. TAVI is also kind of disappearing, and eventually maybe even the mitral valve may go. So this is a very challenging field, and it's a very apt question you ask for people who want to join cardiac surgery. Why do you want to do that? Basically, I think it applies not just for surgeons, it applies to cardiologists, and it applies to everyone in all walks of life, because like it or not, change is something that's going to happen anywhere, everywhere. It's just a matter of time. Nothing stays the same. Unfortunate or fortunate, I can't tell you that, but we must prepare to adapt. And unfortunately, some people dig a hole in the ground and put their head in and refuse to accept that things change. So I like to start by telling a story. It's not new, and it's not my story. I will give you the reference at the end, but it applies to us. So once upon a time, there were 4 little characters who were running through a maze looking for cheese to nourish them and to make them happy, right? This is also something to do with happiness. And let's just imagine these 4 characters, yeah? 2 of them were mice, Sniff and Scurry. 2 of them were little people, as small as mice, but they look and act a lot like people, and we can call them Ham and Haw. And they live in this maze, which has corridors and chambers, some containing delicious cheese. There are dark corners and blind alleys leading nowhere. It's an easy place to get lost, sometimes, like our world that we live in. So in the search for the cheese, these are the personal attributes of these 4 characters. Sniff and Scurry have simple rodent brains, but they have good instincts. Ham and Haw, complex brains, and they have beliefs and emotions. So when you navigate the maze, Sniff and Scurry will often do it by trial and error. They are often lost, they bump into the walls. Ham and Haw are able to think and learn. They have perception, but it is crowded by their beliefs and emotions. And every morning they race through the maze, eager to enjoy their cheese. And of course the mice will dress, they'll run to cheese station C. The little people will also run there each morning until a different routine sets in. Ham and Haw will wake up a little later, dress a little slower, it's like the weekend, walk to the cheese, they're secure and they're comfortable. The little people attitude, every night they return home full of cheese. Every morning they would confidently return for more. We work hard, we deserve this cheese. Sniff and Scurry also return to the cheese each morning, but they sniff, they scratch, they scurry around inspecting. And, they had noticed that the supply of cheese was diminishing, but they were not surprised because this is inevitable and they knew instinctively what to do. Ham and Haw, however, were unaware of their changing environment. They were unprepared to find their cheese missing. And basically, when they find it gone, who moved it? Somebody's moved it. This is not fair. So while Ham and Haw continued to ham and haw, Sniff and Scurry moved, right? Well, Ham and Haw get depressed. What's going to happen to the future? So Ham and Haw returned to cheese station C the next day, expecting to somehow find their cheese. This is kind of a bit like denial, right? But by the way, where are Sniff and Scurry? They have moved. They've gone further into the maze. They've gone up and down the corridor. They just want to find more. And they enter an area where they had never gone. Ham and Haw, in the meantime, are still analyzing. They are angry, right, about this injustice. They are looking for their benefits. They are feeling entitled and betrayed. Eventually, Haw decides to leave because he perceives his own situation. He's laughed at himself. He faces his fears and he says, I'm going to follow the mice. Ham doesn't want to. Somehow, someday, some way, his cheese will be replaced. Perhaps if we just work harder, we'll find that nothing has changed. And you just wait for improvement. So the little people will grow weak, hungry, and eventually they will lose their edge, continue doing the same things over and over again. So Haw's wisdom, sometimes things change and they are never the same again. This looks like one of those times. That's life. Life moves on and so should we. And as he goes around looking for more cheese, he realized he enjoyed the change of pace. The hunt really wasn't so bad. And he finally met Sniff and Scurry in the new cheese station they had discovered. So looking back, the cheese hasn't actually disappeared overnight. It had gotten smaller and smaller. It had gotten old and moldy. And he should have anticipated that that would happen. So as he enjoyed the new cheese, he reflected on what he had learned. He held on to the illusion of cheese when it was no longer there. But he learned to laugh at his own folly. You can let go and quickly move on. And so Haw learned, keep life simple, don't analyze or complicate, change with the situation, envision success, learn from mistakes and use them to plan for the future. And I would say that this handwriting is on the wall right now for all of us. Change happens. They keep moving the cheese. You have to anticipate and get ready for the cheese to move. You also have to monitor the cheese, smell it often so you know when it's getting old, and adapt. The quicker you let go, the sooner you can enjoy new cheese. So change and enjoy the change. And not only that, be ready to change quickly and enjoy it again and again because they will keep moving the cheese. And this comes from this book, which I would strongly recommend. I read this probably once a year, and every year I read it, there is a different meaning to it, and I find something new. So sometimes old cheese, you can appreciate differently if you keep coming back to it, but you need to prepare to move on. So why is this relevant, right? I show you this picture of Mason Sohn's first coronary angiogram, which he somehow made by mistake, and I've titled this an accidental entry into the maze. He never meant to look for it, and in those at that period, it was considered not a thing to do to selectively cannulate the coronary arteries, but somehow by mistake he did it. The patient survived, and they realized, hey, you know, this is something that we can do. 44 years later, right, from that accidental discovery, we have the first human TAVI, right? And you wonder, well, yeah, you know, it was going to come, right? But that very first case, you look at the picture of the people who were doing Alain Cribier and his team, the fear in their eyes, you know, as you're wandering into a maze, whether are you going to survive this? It wasn't so accidental, but they were going into a brave new world. The rest is history. We have all this development, and all the trials started to come out, and I titled this the beginning of the end for surgical AVR. And even as that, you know, as these studies were coming on and on and on, TAVI was showing a lot more benefit, and eventually you all know the partner 3 trial, TAVI was superior. And of course, for the people who were trying to say, well, this is not going to happen, you know, this is not right, you're going to do this denial, the cheese is still there, right? We have still all these patients who have no femoral access, bicuspid valves, or other things, they will still have to go for surgery. Well, this is just last month. Bicuspid aortic valve is now treatable by TAVI, so there goes another big block of cheese. So we are not, you know, it's not new. There are so many technologies that have gone out of the window. I'm sure a lot of people in the audience, you know, will probably not know some of these things, and you'll be wondering what the hell is this, right? And so I would say technology always changes. Things will be disruptive, and we are either ready for it or we are not ready for it. And if you do not accept it and accept that change happens, you will become obsolete together with technology. And this is a perfect example. For those who don't know what this is, pyramids, right? And you'll be wondering, what's the point? What is this doing here? I would say that, okay, it looks great, but this is the evidence of what we will all become if we don't change with the times.
I learned a lot from your lecture. Just focusing on finding new spots for yourself, moving out of your comfort zone, anticipating change. Change, as you know, is very difficult for a lot of people. Who should be doing cardiothoracic surgery, you think, at this moment? And what is a future role for cardiothoracic surgeons when things are moving more and more endovascular, minimally invasive? How should surgeons adapt to that?
As an example, if you look at the vascular surgeons, who I think have adapted very well. When, you know, endovascular procedures started to come out, and especially with the stent graft of the infrarenal abdominal aorta aneurysm, I think there was probably a lot of attempts in terms of making it their turf between radiologists, vascular surgeons, and even cardiologists. But at the end of the day, it appears that, you know, the vascular surgeons have managed to stake their grounds. But in those early years, we had vascular surgeons who basically, you know, were one extreme. They stopped and retrained as interventional radiologists just to get onto the bandwagon. But this day, I think all vascular surgeons have endovascular incorporated into their field. And it is now basically their armamentarium, and I would probably confidently say that vascular surgery probably is more endovascular than open, and they're probably at risk of losing their open skills. That may not be desirable because whatever you say at this moment, nothing is able to tackle everything. You will still need to have the full range of spectrum, And so that would be the same for cardiac surgeons. There will be very complex cases. There's no other solution except surgery. And in order to do that, we still have to maintain a certain degree of competency. One way forward, perhaps, and they are doing this in the United States, is to produce a hybrid surgeon. In other words, you are trained to both do interventional as well as cardiac surgery. I think at the moment they are piloting it. It's going to be quite interesting, but that probably is going to be a solution.
I think it sounds very attractive. I think what the vascular surgeon have done with their discipline is a good one. But my observation about the vascular surgeon also is that a lot of the later generation of vascular surgeon, they are more endovascular than open, which is a good and a bad thing. But I think they are catching up with the times. I sense that you're saying that for cardiothoracic surgery, the surgeons need to probably move and evolve their training program to the direction as well. If not, they might be made obsolete. I think TAVI and some of the structural heart allows the surgeons to get into the conversation now, and I think they should. And I think we are seeing what the model comes out from the US, but I think regionally we should evolve to having the surgeons being encompassed into a endovascular program as well. The other part I felt was that unlike vascular surgery, the investment and the training required for cardiothoracic surgery is immense. You just put someone on bypass, do the surgery. When you need them, they really need to be good surgeons. And as the volume becomes very low, and the first case they take out is not a simple case anymore, it's a complex case, and you ask to tackle and build out the friendly cardiologist, for example, I think it's not going to be easy for the next generation cardiothoracic surgeon to scale out so fast with so many conflicting demands, right? Trying to master endovascular skills, master your surgical requirements, and all the above, and hopefully get married. What type of characteristics and attributes are you then looking for and you think will likely succeed for this very challenging field?
I think the people who go into cardiac surgery are, it's a certain breed, right? Maybe no sane person who values work-life balance, quality of life, might want to go into this field, right? But having said that, you will always have adrenaline junkies. You will have the people who do extreme sports. And I think cardiac surgery, is probably regarded by many people as maybe the pinnacle of extreme, what we call maximally invasive surgery, right? Which is really not the trend these days. So for people who want to go there, you need your adrenaline fix, right? You need to be this high intensity, able to take the stress and put in the hours in order to hone your skills and be ready. It's not unlike people who are training to go Mount Everest, going to the moon, triathlon, whatever field you want to choose. The amount of hours of training, conditioning, learning, and preparing, I think that needs to be done.
I wonder whether there will be any cardiologists who wants to join or cardiothoracic surgeons who want to join, except what you're telling me is quite self-selected, right? Someone who loves the instant gratification, likes a challenge, knows that there's no work-life balance, and ready to give it the 10,000 and maybe 20,000 hours of their life for training as well as work. I'm not so certain though, Kenny. Are you sure these are the only people that should qualify for cardiothoracic surgery?
Let me just put it this way, yeah. There will always be people who want to do challenging jobs. Another recommendation that I will give you in terms of something to read, yeah. But first I will start, would be this movie called Jiro Dreams of Sushi. And Jiro is an 85-year-old sushi master. He's got this 10-seat, 3 Michelin star restaurant in Tokyo, right? And now you'll wonder, why am I talking about a sushi chef and cardiac surgery? Well, I think there are a lot of similarities between sushi and cardiac surgery. Firstly, is that apprenticeship. To make sushi, you need a minimum of 5 years apprenticeship before you are allowed to even start cooking the rice. And then you gradually go on from the rice to the slicing, and finally you serve your customers. So if you were to watch this movie, you'll realize that life as a sushi chef is exactly like life as a trainee, especially a surgical trainee, because they work from dawn to dusk, they have little hours, and it is a long, hard road to success. And yet they do it, for sushi.
What you're saying is that the trainee needs to understand that this apprenticeship journey is going to be long, it's going to be hard, and I think after you come in, you need to be prepared to really devote a long time to master the skill before you like it. I think that's a very important point to drive across. I think there's a lot of books out there, or even speakers who emphasize on the 10,000 hour rule, like Malcolm Gladwell. And you can't get anywhere without putting in the hard work. Not just in any surgical discipline, like I say, even making sushi. Can I just pick your brains about, for a lot of cardiothoracic surgeons, maybe the field is narrowing down. And for the young and to-be cardiothoracic surgeons, should they focus more on thoracic work, cardiology work? And if they do cardiology work, if they have no opportunity to do endovascular, should they be more focused about minimally invasive stuff, robotic surgery, valve repairs, that kind of stuff? And what is your advice to the new and yet to be cardiothoracic surgeons?
Once you want to be a cardiac surgeon, you have to be prepared to be a hybrid surgeon. And all the debates that you have at all the congresses, I cannot deny that there's no smaller wound than a needle prick, right? And there's no way we're going to compete with cardiologists when you are looking at percutaneous versus open surgery. Now, for thoracic, maybe it's they have a better prospects at this point of time because a lot of their surgery are oncology surgery, and when you resect, you will still need to deliver that specimen through a reasonable size hole in the body. And now with video-assisted robotics, it is, I think, as minimally invasive as possible. Whereas for cardiac surgery, it is reconstructive, but somehow we hasn't got to a stage where we can be as good as a needle prick. Of course, however, if the day comes, say thoracic surgeon, you have a new therapy that dissolves cancer, right? Whether it's chemo, immuno, whatever, then they are in trouble. They're going to go out of business overnight. And I would say so with the cardiologists, because the same therapies probably will be able to dissolve plaques, solve coronary artery disease, and make us all live forever. So the only ones who will have the best time will be the geriatricians.
I'm not so sure, Kenny. I think there's a role, and like what you said, we just have to evolve. I remember when we started with thoracic surgeon, VETS was just starting. And I think it really has been quite dramatic. I think what you can do through minimally invasive type surgeries. For example, next time your cardiac surgery can be performed with minimally invasive stuff like a robotic or even a VETS-like surgery. I think it's actually possible. I think surgeons are very enterprising. I have no doubt that they will evolve and put themselves out of a job, and whoever can be the ham and haw can probably catch up faster than the rest. There's always a disease to be treated. And I think surgeons evolve. Iodine came in. No more thyroids to do. The general surgeon do something else. So I think surgeons are very versatile. And I think we are not quite ready to replace a surgeon's hands with AI, for example. So I think surgeons are actually rather privileged because they work with their hands. And I think there's still a big role for surgeons out there. But what are the real attributes? Or is it the hands? Is it an innate talent? Is it just that? Or can you give some advice about how the young should decide whether they should become a surgeon or a cardiothoracic surgeon to start off with?
End of the day, I think there's still that, there are some people who really cannot, who even can't construct a Lego set. So if you can't even do that, then, please don't try lah, but for those who do have some aptitude, I think technical skills is only part of the picture. And of course, there's a huge lecture on how to assess that. And if I can just digress, since we were talking about sushi, I'm sure you are aware that there is a university in Japan that selects medical students based on their ability to do micro sushi as a test of their technical skills. So in that sense, yes, you will need to have a certain minimum standard. But I think if we assume that all the candidates who come in already are basically surgically sound, right? The next stage, if you want to go from general surgery to cardiac surgery, which is most of the way the way we used to train, like you're a general surgeon first, then you move on, right? Then you basically need to have this perseverance, dedication, and the ability to take pain, because it is a painful journey. Learning curve is steep. You need to be kind of, and I'm sure Jack knows because he's spoken about the 4 apocalypse, horsemen of the apocalypse, with all the requirements, and I'll leave him to tell you his that story. But certainly, yes, dedication, perseverance, and most important of all, insight and the ability to take feedback. If you have no insight and you are unable to take feedback, you are probably going to be not having a good time for the rest of your career.
I think you're probably right. I think it's not just peculiar to surgeons. I think any physician need to have good insights beyond technical skill, and the insight and the self-reflectiveness allow you to improve, which is what is more important. I think if you think you're the greatest guy on board, you can't improve, you'll stay static, and you'll never get better. I think everyone is building up to something, and I feel that the attributes of inflectiveness, humility, and the ability to be humble enough to keep on learning and progressing and learning from everyone, not just your senior that you're apprenticing from, but from your nurses who are experienced, from everyone. I think that is an attribute I would look out for in a junior who is willing to train and has the greatest potential to become the best practitioner in his discipline. In anything, I would say. So I value those attributes. So you really need to have a reasonable hands, I would say. Of course, after that, then the attributes of the very logical thinking, the willingness to reflect, take advice and criticism, I think those things are equally important for any discipline to progress. So maybe I just do a quick summary of what you said so far. I think cardiothoracic surgery is still a required field. I need cardiothoracic surgeons to be at my side to discuss the complex cases, to do the cases that still to this day endovascular therapy doesn't work. And of course, to do the bailout for the complication. I think there's a life-saving, very rewarding surgery, but very painful. I think Kenny probably has put off a lot of aspiring surgeons through this talk. But what he has said also probably challenges those who really want to do it, which is good. Don't come into this field lightly unless you want to cut rubbish sushi. So I think what he's saying is very accurate. I think there's always a field for surgeons, and we do need good surgeons. I think for us as community, we probably need to think about how cardiothoracic surgery training should be evolved to fit the times, to run with the times. So I think change is very difficult, even if you see the writing on the wall. I think is a Kodak moment for cardiothoracic surgeons. They probably have to adapt and face the painful truth that as the vascular surgeons saw maybe 15, 20 years ago. So I think we are hoping that there'll be a new breed of surgeons that will take out the mantle, that will serve people like me. I probably need it myself, man. So in the future, I like to ask Kenny though. I know Kenny, for those of you who didn't know, was persuaded by my other very esteemed surgeon, Professor Choi Ling, to drop out from orthopedic training. He was going to be an orthopedic surgeon, to drop out and start training all over again as a cardiothoracic surgeon. Any regrets, Kenny? You could be eating the sushi now, rather than trying to do the 10,000 hours of it.
I would say that probably life as an orthopedic surgeon would have been much easier. Work-life balance maybe a little bit better. But I think at this point, let me just share a little poem. This is by Robert Frost, On the Road Not Taken, right? And I'll just read you that last paragraph, right? Because this is about two roads in a yellow wood, right? And in the last paragraph, to answer you this question, I shall be telling this with a sigh. Somewhere ages and ages hence, two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. So I would say if I had to go to do this again, I would have taken the road less traveled again. But that is really up to every individual. When you reach a fork in your life, you decide what you want to do, and maybe don't regret, because otherwise you're going to regret that maybe you should have taken the other way.
So I think Robert Frost, this poem, I heard it from a lot of surgeons actually. And one of my mentors, Professor Lau Cheng Hock, used to always quote this poem to me. But he always says it's a road less traveled, but rather than the road not taken. Because I think it's for a certain age, I think when you look back and you think to yourself whether I should have taken the road not taken rather than less traveled. I really appreciate the fact that Kenny became a cardiothoracic surgeon rather than orthopedic surgeon. I think you recognize that orthopedic surgery, there's trauma surgery, but lots of it is predominantly lifestyle surgery, unlike cardiothoracic surgery. So, and I'm also very appreciative that Kenny has taken a huge leadership role within the cardiovascular field, especially in education. So the take home is that it's not just what you do for a subspecialty, but I think the contribution can go beyond that. And I really appreciate Kenny's contribution over the years to the cardiovascular community at large in both education as well as leadership. So with that, I'm going to take a pause and we'll see whether there's any questions that we can answer for the call-in participants. So Kenny, any last words from you? Any take-home message from Ham and Hall before we break for Q&A?
Actually, no, I think I'll just leave you with a quotation from Bob Dylan, right? And I think this one, you probably will also know this, yeah? And this is the one that goes, which tells you not to go quietly into the night, but to rage and rage, yeah, into the dying light.
With that, I want to thank you a lot, Kenny, for spending an hour with us to go through this chit chat. I hope you have either encouraged or inspired the right people to come into cardiothoracic surgery. Thanks, Kenny.
Thanks, Jack.
Thanks, Kenny. I must say, rewatching it, I kind of enjoyed that conversation we had. We have a couple of questions from the audience, but before we move on to those questions, I'd like to hear the views of my other panelists when I ask the question, how should the field of cardiothoracic surgery evolve? Let's talk about Asia. Knowing that TAVI is there, people favor minimally invasive stuff through keyhole surgery or percutaneous approach. I'd like to ask Professor Kuan-Ming and John, how you think we should evolve? Do we move more towards minimally invasive or more towards endovascular hybrid type of surgeons type of training? Anyone, John or Professor Kuan?
Thank you, Jack, and thank you, Kenny. I enjoyed that talk.
John, you're quite soft. I can't hear you at all, though, John.
Sorry, can you hear me? I think I need to speak up.
Now I can.
Yeah. Thanks, Jack. Thanks, Kenny, for that brilliant lecture and interview. I'm not sure I agree with everything there, but I think it may well be true. I think, Kenny, you're probably projecting about 20 years into the future. That may well be the case in 20 years, but it's not the case now, I think. So in answer to your question, Jack, I think we have to go with where the data tells us at the moment, where the evidence is, in terms of how we can provide the best treatment for patients what gives them the longest survival, the best quality of life, the best improvement of symptoms. And then we go in that direction. If the evidence tells us that minimally invasive or transcatheter techniques or percutaneous intervention is the best, then I think we have to provide that treatment. But you know, PCI has been around for 40 years and we're still doing CABG. And trial after trial is showing that some patients still benefit more from CABG, multivessel disease with diabetes, with impaired LV function. So after 40 years, we have not seen the end of CABG. So now TAVI is approaching, is appearing, mitral clip is appearing, minimally invasive valve repair is emerging, but the data is not there. But of course, once the data shows that these lesser invasive approaches are the best for our patients, then I think we have to move in that direction. But as long as the data tells us that what we are doing is still the best for our patients in terms of the long-term outcome, then I think we have to continue to offer our patients this, because we have to go by the evidence and not go by emotion. As Kenny said, yes, smaller incision would be better cosmesis-wise. Needle puncture would be better in terms of recovery, but what's best in the longer term? And so we have to tailor. Of course, there are some patients who benefit from the lesser approaches, like the elderly or patients with a lot of comorbidities. The only thing to say is that cardiac surgery is a bit different from other surgical specialties because we need the bypass machine. And if you do it by minimally invasive approach and the patient spends a longer time on bypass, that does increase the risk of the surgery and increase the results of the surgery as well. So there's a compromise as opposed to thoracic surgery. If you're doing a lobectomy, it doesn't matter how long we do it because there's no heart-lung machine in place. So in that sense, with thoracic surgery, I think there's no question we can move towards video-assisted thoracoscopic surgery without compromising the outcomes, as long as we can do a complete lung resection, a proper cancer sort of surgery. But in cardiac surgery, we have to take care that if we do it by minimally invasive approach, that we don't take too long. So we have to master the skill first of doing the technique, and then if we can do it by minimal incisions, then of course we can offer that, and especially if we can show that the long-term outcomes are just as good as the conventional surgery. So that's where I see, I think over time, of course, I think maybe in 20 years, we will get the data that everything should be done, by small incisions, by puncture, devices that have evolved, but we're not at that stage yet. But in the meantime, I think we have to prepare for that. So we should start learning endovascular skills, we should start learning minimally invasive skills, but probably we cannot apply it to everyone yet until the data shows us that such smaller incision surgery is better for our patients.
Thanks, John. Great points. Professor Chiu, your view on this? You are muted as well, Professor Chiu. You would like to unmute yourself?
Hi.
Yeah.
Yeah,
yes,
I agree with John. Actually, I would say I would suggest most of the surgeons just to perform the base of your practice and try to optimize the outcome. So actually, just allow the outcome to compare with each other, because the environment is changing. We learn a lot from the evidence-based medicine. However, we should consider in the Asia context that is practical versus affordable. So not in every different country and also the society could afford the high-end technology. So from the cardiac surgeon point of view, I think the reconstructive practice still need our hand and also our experience to tailor our practice to offer the base practice for the patient. So from my learning curve, actually, I realized the less invasive or minimal invasive is the real trend from patients' desire, their demand, their need. However, this pressure put on surgeons, so move surgeons toward the minimal invasive approach. But that's really a steep learning curve. So that's why when I learn from my practice and also I advocate my practice, I just try to standardize, try to make it doable, and it's repeatable by other surgeons. However, I would agree with Kenny. We need a certain reasonable skill set trained by like exposure, general surgeon, and then learn from our senior colleague, and to have a foundation, the certain skill set basis, and try to attend some workshop, and also try to find some video clip, and also discuss with proctor and some surgeon in this field. And by doing so, I think we can minimize the complication during the learning curve, so that make this practice survive. Otherwise, some surgeons actually find difficulty during the learning curve. They suffer from a bad outcome, so they drop out from the learning curve. That would be a pity. However, some surgeon is excellent in conventional approach. I would say you can remain your practice because the market needs you. And some surgeons have a minimal invasive practice, and we both compete with each other with outcome. So I think outcome is the most important part to compare with each other. We really need evidence-based medicine. However, even we have that evidence, we still could not confirm or make sure whether we are fit that environment or that context to repeat that outcome. Otherwise, surgeons try to compete with each other with evidence instead of their personal series or institute outcome. I would say this is not a reasonable approach.
Thanks, Prof. Again, great points. I think it's a difficult question, I would say. I think the trend is truly a lot of patients are not looking at long-term. You can tell them about long-term outcomes. A lot of them still prefer minimally invasive. This is truly a quick fix. Everyone is looking for a quick fix. They are not looking for long-term. So that's one issue with patient fronting. And of course, there's an alternate therapy. It's not as great as surgery for some subset of patients. I definitely agree with you guys. But when you say you tell people it may not last as long as surgery, you say how long will it last? A few years? Oh, that's good enough. You know, that's the main problem. The other problem is established surgeons have great outcomes with the standard approach. And to ask them to say, why don't we try minimally invasive? It's not easy to do a switch. And when the senior surgeons don't switch, there's no training opportunities for juniors. So you're locked into this cycle of scaling up. So I think that's really a real issue. I got quite a few questions now from the live chat, and looks like some of them are addressed to Professor Win Jaw, actually. A few questions, maybe I can group them. One from TTK. What advice do you have for women trainees interested in cardiothoracic surgery? From Laura, what are the difficulties and limitations of being a cardiac surgeon, particularly in Myanmar? And Kathy, specifically for Prof. Win, what is there a future for cardiothoracic surgeons? And Dr. King also asked, I'm a young cardiovascular surgeon from Myanmar. I would like to know your expert opinion of how many years is required to become an expert endovascular surgeon for a new cardiothoracic surgeon. So maybe Prof. Win, do you like to take this as a bunch? How do we address the needs for female cardiothoracic surgeon? Is there a role in Myanmar for cardiothoracic surgery? Is it worthwhile training in endovascular after you do open surgery? Prof. Win?
Actually, from my point of view, actually, some people think cardiac surgery is dying. Actually, as a surgeon, actually, I would say cardiac surgery is not dying. New and evolving technology has always guided cardiac surgeons. Development of new technology has always shaped and driven the field of cardiac surgery. future cardiac surgery like endovascular surgeon or minimally invasive or whoever will require both surgical and interventional skill as the application of endovascular and minimally invasive techniques expand. This is the incredible growth of cardiac surgery as a specialty. For example, as we all know, for interview cases, surgeon must be an active participant in multidisciplinary heart team, sometimes helping to lead these cases. I believe future of cardiac surgeon actually hinge on surgeons' abilities to improve techniques, innovate in therapies and diversity the practice. That's why, like Kenny already mentioned, cardiac surgeon must retrain and stay at the forefront of technology advancement and actively participate in prospective research, maintain the ability to evolve the ever changing actually field of cardiac surgery to become a cardiac surgeon, expert cardiac surgeon, or minimally invasive or interventionist. Actually, they need a lot of training. For example, actually, for example, pilot experience of pilot totally depend on flying hour, not the office hour. They need staff training, intensive trainings, and then they look for leadership and they look for actually great mentor. Or if they have inspire and they have desire, they have passion, and one day they become a good cardiac surgeon or endovascular surgeon. They can, if they want to.
Win-Win, looks like you're very popular. A lot of the panelists, a lot of the audience want to ask you questions actually. So from May Tutu from Myanmar as well, how have you overcome the various challenges you face in your career as a lady surgeon? And Professor Ang asked Professor Win, why is there still so few women entering the cardiothoracic field? And maybe you'd like to tell me what are the challenges particularly? Is there any challenge at all? Do you think there's no difference?
Actually, yes. Actually, I have a lot of challenge, yes. Actually, my road is not very, my road is rough, actually. Like other women, I face some gender issue. My pregnancy, it could have hindered my ability to set up in my career, but I was lucky. I had many wonderful teachers who gave me hand-on trainings, insightful guidance, and fantastic opportunities to go in my life as a cardiovascular surgeon. Actually, today, I'm proud to be called a cardiac surgeon or wife, mentor. I owe my gratitude to my teachers, my life coach, locally as well as abroad. International mentor like Professor Ang who Dr. Bruce French. In local, Professor Kyaw and Professor Kyaw, all are my mentor. I am passionate about teaching operation, training my juniors, and mostly treating my patients. Being a woman, a professor and mentor to my students, mainly ladies, I always tell them this field of study is full of difficulties, both physically and mentally. If they are not strong and enthusiastic enough, actually nothing great will be achieved. My advice and suggestion is that there should not be any gender bias or whoever, whether it be a man or women. The most important things are commitment, individual competence, passion, and desire to become a cardiac surgeon. Actually, why I shot a small number of women entering cardiovascular fields. Firstly, this is only my feelings. Women's cardiac surgery life is so difficult and demanding job. Secondly, cardiologists have been performing more and more catheter-based procedures. Cardiovascular surgery isn't glamorous anymore, some people thought. As a result, there was a significant drop in interested in our field since several years ago. Lastly, women remain stagnant in clinical and academic leadership position in cardiovascular surgery. This influence career choice of younger women.
So, is there an issue
Not-
in Taiwan or Malaysia for the small number of female surgeons? Dr. Chiu, you're muted. John, you're muted. Maybe you can unmute yourself. Are there a lot of female surgeons in your country as well?
Yeah, it's getting more and more female cardiac surgeon. At my age, when I was a trainee, I don't think there is one female cardiac surgeon. And 5 years apart from me, it's getting more and more now. But it's still quite few. So, but now we have more than like 20, 30 female cardiac surgeon overall among like 400-500 cardiac surgeon.
Wow. John, in
Yeah,
Malaysia?
so in Malaysia, we have, I think, about 50 over active practicing cardiac surgeons, and only 2 are females. But we have, as Kenny mentioned, we have a new national training program for cardiothoracic surgery, and we have 25 trainees now. Out of these 25, 4 are females. So that proportion is 16%. So it's encouraging. And I think over the years, I think more females are likely to join the training program. I must say all the 4 females we have in the training program are doing very well. And we are giving them all the encouragement we can. So I think it's true that at the moment we have very few females in cardiothoracic surgery in Malaysia, but it's quite encouraging that more of them are coming into the training program. So I think over the years, I think we can expect that the numbers of female cardiothoracic surgeons in Malaysia will increase, I think, to around about 20-25% probably.
So I think the life of a cardiothoracic surgeon is really not easy. I'm a cardiothoracic surgery wannabe. I started my first year medical officer as a cardiothoracic surgery resident, and I was under Kenny, actually, who was my senior registrar. I was doing 10 calls a month. I was either pre-call, on-call, or post-call. And my ex-girlfriend then told me, if you're going to do this, let's not get married. So it's not just hard on you, it's hard on the family. So I really appreciate the surgeons doing this. I want to address a few other questions. Maybe Kenny can take this. You know, we have this desire for trainees to switch track, and early adopters always forge a new path. So Christine Teo asks, there's already some hybrid surgeons in heart center and established MRI surgeon at NUH, but taking the point of John, evidence takes too long for us to plan for the future. So how do we encourage young consultants to develop future-ready skills? Will cardiology support the concept of a hybrid surgeon doing valve interventions? So Kenny, you want to unmute yourself first?
So as I mentioned, I think in the US, they are already doing this experiment where you train in the catheters, cath lab to do PCI as well as open surgery. And I think as I partially answered, our TAVI teams are already cross-training in that sense, because we have a surgeon, we have an interventionalist, and sometimes they do exchange roles in terms of the parts of the procedure. But of course, whether at the end of it, a cardiac surgeon can independently do right catheter, or a cardiologist can independently do a CABG, at this point, our training program doesn't cater for that. So I think we really need to have more cross-training across and come up with a specific program. But of course, the entry criteria and the kind of candidates that will have to be very carefully considered. But certainly, I think this may have to be the future. And then you get the best of both worlds, and we don't have this divide between surgery and catheter.
Yeah, I think we definitely don't want this divide. But I would like to say that, like what John said and what Professor Chiu said, is about outcomes, right? So sometimes if you have gained a competency, why not? For example, do you trust me to do your open heart surgery as an interventionist? It's the same scenario. So if you achieve the competency in whatever field you're doing to be able to do it as well as the guy who's fully trained, then why not? but the journey is very hard. So I feel that unless you build it into the training program for the next generation of cardiothoracic surgeons, it's very difficult for them to scale up to that level of competency to compete for outcomes. So I think it's all about outcomes. It's all about competency. And there's also another question for another participant. What's your advice to a lady who wants to pursue a career in cardiothoracic surgery but has plans to start a family? So I think Prof Win started a family while in the midst of training. You need very supportive environment. And of course, there's a lot of sacrifice. I think it's not easy. Not asking you to hold back your family, really, that's also not a wise idea. So is there any other comments from Prof Win, John, or Prof Chiu?
Actually, my advice, the road is tough, but it's entirely worth it. Seek out male and female mentors early and often because it is very, very important to be taken under the wings of others in the field. It's also very important to have a constant thirst for knowledge because this is a growing need to adopt skills to accommodate the patients who are often sicker and more complicated than the first presentation to the cardiologist. As you advance in your career, empower others and be approachable. Help your colleagues and your juniors, and you will never regret the decision to pay it forward. Moreover, have clear goals and objectives. If you are not strong and enthusiastic enough, nothing great will be achieved. This is my advice.
So I would also say, it's not impossible. I think, right, and I think we are getting more and more female cardiac surgeons. I think 10 years ago, we probably had none. Now we have 5 in Singapore, and 3 of them are in my institutions, and we have another one in the pipeline. And the last year, we had 2 ladies who exited the program out of the 3 from our center. And one of them, I think she delivered, and she's now pregnant second time. So, I would say, yeah, it's not to say that you cannot have a family life. It is possible. It is possible to achieve work-life balance, but I think you must have a system that allows it. You must have an institution, culture that allows you to do this. Whereas if you're going to be on a mindset where you are working 24/7, and maybe Jack should show his Horseman of Apocalypse slide. If you expect everyone, to work 24/7 with no life, then of course it's impossible, right? Let's not talk about ladies having families. Even guys, will not be able to have families. And I'm sure that there are a lot of male cardiac surgeons who are not married, or if they're married, they're divorced or whatever. Yeah, so it impacts on both sexes. And it is a tough life, but as I say, culture, mindset, and in this day and age, we have to make allowances for people to have work-life balance. The trick is how to go about doing it.
Any other comments from John or Prof Chiu on this?
I would agree with Prof Win and Kenny in the comments. I think the journey is hard, but it's only hard in the first 10 years because it takes 10 years to acquire the skills, both technical skills, cognitive skills, and the judgment. After 10 years, I wouldn't say it is very tough to be a cardiothoracic surgeon. It's very enjoyable. In fact, it's very fulfilling. So actually, I'd like to encourage those who are interested in the specialty. Yes, it's difficult at the beginning. It's a long journey. It's 10 years at least of hard work. Beyond that, it's actually a very fulfilling career and a very enjoyable career. So if you're interested in the specialty, I would encourage you to go into it. But expect the specialty to evolve, to change from what it is at present, as Kenny has so well presented. So be prepared for that. But I think it is a great specialty. You will really enjoy it at the end of the day.
Yeah, I totally agree with John. I think as a cardiac surgeon, it's very honored. Yeah, it's tough, but the early beginning of our training is tougher. So after you passing the learning curve, you climb up the mountain, you will find there's still second curve, but that's more rewarded. So I would say we still need to trust our young generation. Life is always find a way. So maybe the more of our age, the more difficult for us to change. So young generation, they will find a way. I think the current status of our practice is not the program of our senior fellows. That's ourselves to invent, to develop. So allow the young generation to develop their career and just to be a good proctor, to do your best practice. They will choose which one to learn and they will find a way out. I think they still have a great future.
Thanks, Prof. Chiu. I'd like to end off with this final Q&A comment by one of the participants, which I want to read out from Dr. Hong Chi Suen. I don't think anyone need to worry about the future of cardiothoracic surgery. This question has been asked many years ago when Dr. Robert Guyton was finishing his training at Massachusetts General. He told Gerald Austen, then the chief of cardiac surgery, there's worry about the future of cardiothoracic surgery because it seems to him that everything in cardiac surgery has been done already. The answer that Gerald Austen gave was, don't worry, there's always room at the top, which means that if you're good, you can always find new things to do. History proved Dr. Guyton correct by becoming one of the most prominent cardiac surgeons when he was chief of surgery at Emory Medical Center. And as Kenny has said, the world is really always changing. No matter what we're doing, we just need to adapt and we'll be fine. There will always be patients for us to help. The only way for us to predict the future is to invent it yourself, like what Prof. Chiu has said. Be innovative as a surgeon and invent the future yourself. So it's very inspiring words from Dr. Hong Chi Suen as a participant dialing in. And he typed this long message. I felt I had to read it out. And this session is really meant not to discourage, but to encourage. I think I've seen so many people state very passionately that this road taken by them, less traveled, harder, is a true path for them because they chose wisely and they work hard at it. So I want to encourage the future generation of surgeons to be in Asia. Please go on this path. I think it doesn't matter male, female, whatever circumstance. If you have passion, you have a desire, you're willing to put in 10,000 hours, I think there's enough support. The field is evolving. You have to find a niche for yourself. And I really want to support it at APSC level. Previously, we have provided scholarships for surgeons, even from Papua New Guinea, to come and train with us in Singapore. So I think the field is evolving. The greatest need is in Asia. And knowing the tsunami or all this non-communicable disease coming to Asia, there's great need. So with that, I'd like to thank everyone for participating tonight. Before we finish, there's a surprise. We're going to play a finishing video for you guys to watch. And this will inform to whether you want to be a surgeon or not, if you can watch the video. And I'd like to thank everyone for calling in tonight. Thank you and keep safe. Thank you.
それ自分がやろうと思った仕事、それにもう没頭しなきゃダメです。好きにならなきゃダメです。それ自分の仕事に惚れなきゃダメなんですよ。ただあれがダメこれがダメって言ってたら一生経ってもまともなことはできないと思います。だから自分がこれを覚えようと思ったらそれもう必死になって死に物狂いでやるということが成功にもつながるだろうし、それから自分が良くなった時に立派な事件になれるんじゃないかなと私は思いますけどね。
So with that, he spent his whole life cutting the perfect sushi. And I think I would demand no less of our next generation of cardiothoracic surgeons to put in 10,000 hours before you lay your knife on our next patient. Thank you very much for your time tonight. Thank you and bye-bye.
Thank you.
Bye-bye. Thank you.
All right.
Bye-bye.